Hello, and thank you for joining today's session in LHSN Safer Care Accelerator webinar series. My name is Dee Dee Thompson, and I'm a policy fellow here at the Imperial College Institute for Global Health Innovation, and I lead on the LHSN program, which is a joint initiative with the World Innovation Summit for Health. We're excited to be joined today by Riccardo Chiarelli, who will be discussing what we can learn about patient safety from the nuclear industry. But before I turn it over, I'd like to give a very brief introduction of our speaker, and then we can go ahead and begin. So Riccardo is a senior manager at an international organization for nuclear safety, where he coordinates nuclear safety projects across the globe and also leads international peer review assessments of operational safety in nuclear power plants. He's also a technical advisory board member for the Johns Hopkins Medical Institute, as well as a lecturer and visiting professor at several universities, including the World Nuclear University and the London School of Economics. So without further ado, I'd like to hand it over to Riccardo.
Thanks, Didi, and thanks to the Imperial College for leading this beautiful initiative. And thanks also to all of you for connecting from different parts of the world. So the title of this webinar is Patient Safety, What Can We Learn from the Nuclear Industry? So maybe the title can seem bizarre at first, but I want to explain that it makes totally sense, and there is a huge potential to improve performance in the healthcare industry. Let me also clarify that I'm doing this presentation as a private individual, and I'm not representing any organization. So as an introduction, I want to give a brief summary of how patient safety looks like from an external perspective. So with an extreme simplification, an IOM report in 1999 surprised everybody, stating that up to 98,000 Americans die every year from preventable adverse events. That was quite shocking, and a number of initiatives started, including a World Health Organization's Alliance for Patient Safety. About 15 years after, other studies and researches showed that probably the IOM got it wrong. Actually, the real number was underestimated, and the new figure was about 440,000 deaths annually. It seems that the situation got worse. Probably what really happened was that the healthcare industry simply got better accounting. Actually, one of the issues is about data and metrics. There are no official clear metrics to count these adverse trends. And as Dr. Pronovost said, if you don't have data and metrics, you don't know how you're doing. You don't know how you compare to anyone else, and you have no way to judge whether your efforts are making a difference or not. So here is the first lesson to learn from the nuclear industry. Data is important, and what you can measure is easier to manage. And here we go. All the nuclear power plants in the world have agreed long ago on a set of metrics that are reported regularly. These metrics are designed to take into account several factors, but the main idea is to be able to compare each other's performance. Here, I want to present only some of the metrics that are used. There are more, but for simplicity, I report only 4. These indicators are intended principally for use as a management tool by nuclear operating organizations to monitor their own performance and progress, to set their own challenging goals for improvement, and to gain additional perspective on performance relative to that of other plants. It is also widely recognized that a good set of overall performance indicators can provide a partial but important and useful measure of how well a nuclear plant is managed. The indicators I show represent the median or the mean values of the entire nuclear industry. They show the performance of the entire nuclear industry from 1990 to 2014. On the top left-hand side, there is the availability to produce electricity. It is the percentage of time that the median of all the nuclear plants in the world are ready to produce electricity. Obviously, you want to maximize it without compromising safety. And as you can see, performance improved significantly in the last 25 years. Increased immediate availability of more than 10% is quite huge, and it is like adding many new plants to the electrical grid just by increasing reliability. The other three indicators are more related to safety performance, and you want to minimize them. On the top right-hand side, there is the number of automatic stops of the reactor. If something is unexpected, the reactor is capable to automatically shut down. So this indicator shows the mean of all reactors in the world. Again, we can observe a significant improvement in the last 25 years. On the bottom left-hand side, there is the industrial safety accidents. This is a common indicator in many industries, and it relates to personal safety from injuries. Another significant improvement over more than 2 decades. The nuclear industry is one of the safest places to work. And finally, on the right-hand side, lower row, the collective radiation exposure for a particular type of reactor is presented. These represent the collective dose to workers only in a nuclear power plant, and we can appreciate another significant improvement. The rest of the presentation is to show how the nuclear industry managed to achieve these results and how this can be achieved also by other industries. I wanted to show this slide because I want to show you the political and cultural complexities of the nuclear industry. This map shows the location of the nuclear power plants around the world. The matrix I showed you earlier are reported by all these plants. And as you can see, data are collected from a variety of countries, from the US to Russia, from South Africa to China, Pakistan, Brazil, and so on. There is no excuse of language, culture, or any other barrier when safety is involved. And this is another important lesson to learn from the nuclear industry. Safety is the priority, and the success of the industry is the success of each individual plant. It is therefore important to go beyond boundaries and realize that it can be done. Actually, it has been done. If the nuclear industry achieved it long ago at a global scale, other industries can achieve it as well. And in the healthcare industry, we are talking about saving lives. What I'm describing about the nuclear industry is the establishment of international cooperation. This can be in the form of the World Association of Nuclear Operators, WENO, or the International Atomic Energy Agency, IAEA, or other entities. The initiator event for the creation of this international cooperation has always been a major event, and the goal is to achieve industry-wide excellence. After these major events, for example, the Chernobyl accident, the entire nuclear industry realized that we are hostages of each other. To understand it better, think about an accident happening in a hospital in Japan. Probably nobody in the US will know anything about it. Actually, probably even other hospitals in Japan would be unaware of it. Instead, a nuclear accident in a plant in Japan costs billions to the nuclear plants around the world, and even shuts down a number of plants in other countries. So we cannot afford low performance anywhere in the world. An accident anywhere is an accident everywhere. Now, again, I mentioned Dr. Pronovost, then when it asked, why is it when a death happens one at a time, silently, it warrants less attention than when big disaster happens? Actually, what the safety numbers in healthcare say is that every day, 2 747 airplanes are crashing only in the US. Every 2 months, a 9/11 is occurring again, and we would not tolerate that degree of preventable harm in any other forum. I'm also well aware that the nuclear and the healthcare industries have some big differences. For instance, sooner or later, everybody knows that he or she will need healthcare, and we cannot live without it. On the other hand, the nuclear industry is constantly challenged. However, both industries have also many similarities. Both require high reliability, have low acceptance for mistakes, and the public has strong expectations. It is therefore important that the highest standards of excellence and accountability drive them. Station performance is compared to excellence. And here, there is another lesson from the nuclear industry. We do have internationally agreed standard of excellence. Again, all nuclear power plants in the world agreed on these standards that basically describe what the perfect plant should do. These standards define the objectives and not the methods to reach those objectives. Our processes are performance-based, not compliance-based. The nuclear industry developed a unique process to strive for excellence in operation, and this process can be adopted by other industries as well. International safety assessments can have different forms. For example, the IAEA has developed operational safety assessment review teams, or OSART missions, or WANO has developed a peer review program. These international assessments that began more than 20 years ago have played an important role in the international nuclear industry's improvement safety record. These programs cross-share best practices, hazards, problems, and actions taken to improve safety and operational performance. This review assessment process is an in-depth, objective, interdepartmental evaluation by an independent international team of peers with extensive expertise in best practices. In the case of the IAEA OSART mission, the member state is asking for such a kind of safety assessment. In the case of WANO peer reviews, although voluntary, all nuclear power plants committed to the review process. And a trained team spends 2 to 3 weeks observing plant activities and material conditions, conducting interviews, and reviewing performance and safety-related documents. The team identifies strengths that could benefit other plants and weaknesses in plant safety and reliability that should be improved. It is important to note that these assessments are independent of a regulatory body and lack a regulatory authority. Non-regulatory format fosters open discussions between the review team and plant managers. A candid, confidential report describing the team's finding and recommendation is given to plant management following each assessment. Safety assessment reviews are based on observation of people activities. And this is very important because the most important thing I have learned over my career is that if you want to understand performance, you must observe people work. Observe their activities, their surroundings, and their management. The review process ensures that the assessment is deep and focused by using people who do a similar job at their station. In addition, plants are sure that the review is fair and credible because the process has been validated. Reviewers are trained to use a performance-based approach, to identify gaps in station performance rather than in processes, and to focus on significant gaps to excellence. Here it comes one caveat of lessons number 1 on data and metrics that I mentioned earlier. If you rely only on metrics and numbers, you won't have the full picture. Data is important, but even more important is observation of people who work. And this is another lesson for the nuclear industry. Observe the people who work. Pay attention to detail. expect to see only the highest of standards and question anything that's out of the ordinary. This is the power of the reviews conducted in the nuclear industries. Reviews that are based on observation. Long ago, we realized that you simply could not judge the quality of operation and hence the safety of a nuclear plant unless you could know what was going on in the workplace. I will come to the point that the same is true of hospitals as we proceed. Looking at the reports, reviewing data, and interviewing people all help, of course. But observing actual practices in the workplace was found to be absolutely necessary to get the full picture of safety performance. Reviews were built around that concept. Teams of a dozen or more trained professionals spend 2 to 3 weeks at each nuclear plant, and they learn how to constructively interact with nuclear plant management and workers at all levels. And they observe every facet of operation of the nuclear plant. These reviews, of which well over 1,000 have now been conducted, are the cornerstone of the progress and success in improving nuclear safety and reliability that I described earlier. Now, think about one question. Would you drive a car using only the rear mirror? Or if you are able only to see certain things in the road and not everything? Of course you wouldn't. But every day, managers are allowed to steer organizations even though they are not able to clearly see where that organization is, where it is headed, and the potholes and obstruction that lie on the road before it. Now, if you want to get from point A to point B, your driving abilities allow you to get there by knowing how much gas to apply and how much braking or steering to apply. However, this is only the case if you can clearly see the road and your surrounding and know when and how much to do what. This element of seeing the road or assessment is one of the least talked about attributes of management. Assessment skills are among the weakest of the typical manager's abilities in any industry. And how many times we hear industry leaders pleading ignorance of what's going on in their organizations. And since we are using the example of cars, think about the latest Volkswagen emission scandal. Nobody knew anything about that. So it is important to notice that one key element on the standard of excellence is to have clear lines of responsibility. And here it is another lesson to learn from the nuclear industry. Responsibility for each action, process, or activity is clearly defined. Continuing with the car analogy, if the vehicle or organization is a small one, the driver can do the assessment by himself. But if it is a large one, like a cruise ship, then multiple people are involved in watching the route and causing the ship to follow the intended course. In the analogous large organization, the captain, who can delegate authority but not responsibility, depends on the other assets, such as line managers and oversight groups to help watch the road. It is the shortfalls in the watching or observing by the driver or captain and by these other groups that are the basis of the peer review process. People in the nuclear industry observe performance and then act on those observations to improve performance with a primary focus on safety. Now, at this point, I guess probably you have guessed that other industries can apply a similar peer review process and the art of observation to improve performance. Some pilot peer reviews have been conducted in the past with promising results in the healthcare. About 10 years ago, peer reviews were performed at 14 different hospitals. The peer review teams observed activities in virtually all areas of the hospitals, from the operating rooms to laboratories to intensive care units to the emergency departments, etc. detailed reports of each review for hospital and system management were written. Experts in observation methodology in the nuclear industry and the medical professionals worked together and withdrew the same conclusion I talked earlier about nuclear plants, and that is, if you really want to know the quality of patient safety, you have to observe what takes place in the workplace. Now, I have to thank also Mr. Zach Pate, one of the founding fathers of WANO, for sharing this observation with me. He was in the team that performed this peer review, so I can give you some practical examples of things that were observed. So, for example, a hip replacement patient was observed from the pre-op preparation very early in the morning, through surgery, and then through post-operative care on the hospital floor. The patient was an otherwise healthy woman in her late 60s. A nurse came to her room about noontime to change dressing on the surgical site. The nurse shook hands with the patient's husband, then turned to the patient on her side. She was courteous and careful, quite professional up to this point. However, she then removed the bandage and blood reservoir and the drainage tube with her bare and unwashed hand, actually touching the hip wound and drainage tube in the process. The nurse then laid the bandage and blood reservoir on horizontal ventilation louvers on the window sill. This allowed the room ventilation air to blow over the contaminated material. On another occasion, the teams observed a patient with methicillin-resistant Staphylococcus aureus, MRSA, being moved from the intensive care unit to radiology. The patient was rolled through hallways past other hospitals' employees and visitors. The patient was not wearing a mask and was constantly coughing, trying to clear his throat during the transfer. Now, this is a lot of detail, but I'm sure you all agree that these are egregious examples of weak infection control. The first could lead to a disastrous setback to the hip replacement patient. The second could lead to the spread of MRSA, a sometimes fatal staph infection. One further example. Management of the hospitals had issued a policy that a formal timeout or pause would be conducted before the commencement of each surgery. During the peer review, the hospital's system was reporting that timeouts were being conducted before beginning surgery over 90% of the time. However, teams observed 32 surgeries and timeouts were actually conducted less than 20% of the time, and some of those were quite cursory. In one case, the wrong patient was brought into the operating room, and this was caught not by a timeout that was not conducted, but later by an alert nurse. So now, many other shortfalls in performance were observed in alarm responses, alarms linked to patient safety, in improper use of procedure, not following policies or procedures at all, in hand sanitation practices, in patient identification practices, in simple things like food delivery, with the most extreme example being a hamburger delivered to a patient with a tracheotomy. So now, I do not want my talk to sound as I'm trying to be uniquely critical of medical professionals. The kinds of things observed are not different in some concept than what we saw in the nuclear industry, especially when we started. People are people, and there is abundant evidence from many industries that performance all too often falls short of expectations. A good peer review program ultimately results in a lot more management involvement and supervision, and a lot more accountability. Unfortunately, these pilot peer reviews didn't grasp enough momentum to become a practice. After those pilots, little has been done. Now, Dr. Pronovost is trying to start again a peer review program for healthcare, and more resources are needed. Now, I want to discuss a bit the barriers for starting a peer review process in the healthcare. One of the barriers is a persistent culture of fear, autonomy, and secrecy. The nuclear power industry has strong organizational and professional culture that play an important role in the success of the review model. Information is openly shared, and organizational learning is a trait of the safety culture. On the other hand, a history of autonomy, demanding perfection, and exacting punishment when errors occur has created a deeply rooted culture of fear and secrecy in healthcare. Therefore, I believe that the new assessment process must be non-punitive, focus on learning rather than judging, be collaborative rather than competitive, and be interdependent rather than independent. There is also a lack of trained evaluators. Although healthcare professionals are now more aware and knowledgeable of the system's approach to improve patient safety, few have the formal training in systems engineering or safety science required to identify and mitigate hazards. So training needs to be assessed. Another barrier is lack of validated evaluation tools. The healthcare currently lacks valid and reliable tools and processes to conduct the reviews, and will have to develop pilot tests and validate them. The development of such tools could be a priority for research funders. There is also a lack of infrastructure. The healthcare lacks an organization like the IAEA or WANO to coordinate assessment activities. However, these pilot tests offer ideas for how assessment might be organized in healthcare. It could grow out of professional societies, hospital association, or a newly charged non-profit organization similar to WANO. And finally, time demand and cost. It is unclear exactly how long reviews will take in healthcare. The amount of time will depend on the depth and breadth of the evaluation. Recent pilot projects had duration of 1 to 2 days, but I feel they are too short. And about cost, well, this is quite unknown. But given the substantial amount of preventable harm and costs associated with medical errors and limited improvement in patient safety compared with the nuclear power industry, the business case for conducting these reviews is likely sound. Now, I just want to recap the main lessons that I want to stress. The first one is data is important. What you can measure is easier to manage. You want to know where you are in your journey to excellence. When you start an initiative, you should be able to see if it is effective or not, and you want also to be able to compare to others. Another lesson was about safety as being the priority, and the success of the industry is the success of each individual entity. Safety is very much linked to performance. You cannot separate the two, and working collaboratively will help everybody. The objective is to cure people. Another lesson is to have a set of internationally agreed standards of excellence. You want to compare yourself against excellence. Therefore, you need to define what excellence is. What would you expect from the perfect hospital? How it should look like? Another important lesson we talk about is about if you want to understand performance, you must observe people work. Focus on the outcome, not on the process. You need to have a fair assessment of where you stand compared to excellence and what you need to do to improve performance. And finally, it is very important to have clear lines of responsibility. Leadership and accountability are inextricably linked. Leaders should be attentive to people's needs and coach them when inadequate behaviors are observed. And it is important to have a blame-free culture where people can raise concern. without fears of retaliation. So here is my conclusions. The peer review process do work. It has been proved in many industries, so it is easily available and you can easily use it. And in the next medical emergency, you should call the 911, but make sure that the patient doesn't ask you to take him to the nearest nuclear power plant. So this concludes my presentation, and I'm open to question if any.
Great, thank you so much, Ricardo. That was an excellent webinar, and very grateful that you took the time to share that with us today. I had one to start with, if that's all right, and perhaps might be a somewhat provocative or challenging question. But you were recently quoted in a Forbes article saying the following: "We like to say the entire industry is held hostage to each other. If an accident happens in a nuclear power plant in Japan, the nuclear industry in the US and everywhere else will need to be impacted. If we want to succeed as an industry, we need to make sure everyone is at the highest level of excellence." So to what extent do you think this could be reasonably applied within healthcare, particularly given the huge variation in health system structures across countries?
Thank you. This is a very good question. First of all, the variation and differences in cultures and countries, I try to explain in my speech how difficult it was already 25 years ago to agree it, but it was possible. And 25 years ago, we were still very close to the Cold War, and it was possible to go beyond these barriers. I think if the motivation is to reach excellence, to improve patient safety, and it means saving lives, this motivation should be found. In addition, studies and research shows that thousands of people die every year because of medical errors or things that could be prevented. And I think this is quite unacceptable and for an entire industry. So the peer review process and this collaboration, it is very important, and we cannot think to solve individually, and it is much easier to do it collaboratively.
Absolutely agree there. Along a similar vein, and I believe you've touched on this a bit throughout the presentation, but what would you say to those skeptics who might say that healthcare is too complex and too different to be compared to other industries?
Well, I would tell them that basically, what is their objective in healthcare? I thought that the objective is to save lives. So, and I cannot see an improvement in patient safety in the last 15, 20 years. So if somebody is skeptic, I accept this, but they should convince me that something should be done and has been done. And here we are offering an easy fix, an easy solution for this problem.
Great. Well, thanks so much for answering that, and I think that certainly resonates with us here in the room. I realize that we're starting to approach the end of the webinar time, so just to sum up with one final question. I know on your last slide you had mentioned a few key takeaways, but if you had to narrow it down to one or two key takeaways or recommendations that you'd like participants to walk away with, what would those be?
I think the participants should think about what would they expect from the perfect hospitals and how excellence looks like in healthcare. And so this should be the mindset for every activity or every tasks during the work. I think that's the main point. Try to reach excellence and never accept anything else than excellence.
Great. Well, I can't think of a better line to end on. So just want to thank you again, Ricardo, so much for taking the time to speak with us today and for participants for joining. We'll also be making a recording of this session and posting it to our website, which is www.leadinghealthsystemsnetwork.org. So thanks so much and have a great day.